Good afternoon, ladies and gentlemen. And now please welcome the President of the American Epilepsy Society, Dr. William Theodore.
Thank you. I'm delighted to welcome you to the 22nd Judith Hoyer Lecture in Epilepsy, Treating Seizure Patterns, Past, Present, and Future. The Judith Hoyer Lecture in Epilepsy combines the discussion of state-of-the-art in a specific area of epilepsy and the impact it may have on patient care and outcomes. We are proud to partner with the National Institute of Neurological Disorders and Stroke in presenting this annual session. We are also pleased to continue to make this lecture accessible to both professional and public audiences. To that end, for the 7th year, we are streaming a live webcast of this public lecture, so many more may listen live or to the archived recording afterwards. I want to acknowledge the support of educational grants from Upshur Smith and the support for the live stream of this lecture by Jazz Pharmaceuticals. The AES Extraordinary Contributions Award is designed for those who have made exceptional contributions across multiple fronts, including science, education, leadership, and advocacy. This award is only presented when the board of directors determines there is a candidate whose accomplishments embody the spirit of the recognition. I am honored to present this award on behalf of the AES board to Eileen Murray. Eileen has been CEO of the American Epilepsy Society since December 1st, 2013. Her strategic goal-focused mindset and results-oriented execution have been instrumental in driving organizational growth and impact for the society. This, in turn, has accelerated AES's ability to fulfill its mission and support those who seek to understand, diagnose, study, prevent, treat, and ultimately cure epilepsy. Eileen has led the organization during a transformative period in its evolution, building a diverse, high-performing professional staff and partnering with AES's board of directors on significant governance and programmatic advances. In partnership with elected leadership, she has guided 3 strategic planning cycles, including the most recent, which centers on organization commitments to improving the lives of people with epilepsy through cross-disciplinary work, inclusivity, and equity, and expanded investment in research and evidence-based practice and education. Supporting the organization to increase visibility, credibility, and influence in the epilepsy and larger medical community is instrumental for advancing knowledge and improving outcomes for persons with epilepsy and their families. In addition to service with AES, Eileen served on the National Advisory Council to the National Institute of Neurological Disorders of Stroke, the Advisory Council for the American Academy of Pediatrics Center for Children and Youth with Epilepsy, and was the recipient of the Association Forum of Chicagoland's highest award, the Samuel B. Shapiro Award for Chief Staff Executive Achievement. Eileen, please join me at the podium to receive this well-deserved honor. Now, I'll give this to you and step aside. So you hold it, I think. And then I step aside here. Okay. Are you?
Thank you so much. I am deeply honored to receive this award and humbled when I look at the list of previous awardees. It's rare when I tell someone where I work that I don't hear in response that they or a family member or someone they know has had an experience with an epilepsy diagnosis. Often that story begins with fear and frustration, but ends with grateful and effusive appreciation for the wonderful work of their physicians, allied healthcare providers, community of support, and the researchers who continue to search for better treatments and ultimately a cure. I am grateful for the praise that I receive as CEO of AES, But I want to thank the extraordinary staff team that I've had the true joy of working with during my tenure. Their commitment to AES goes above and beyond every single day. And we do what we do because of what all of you do every day, whether as a clinician, researcher, or advocate. I especially want to thank everyone who has served as an officer, a board member, a chair, a committee member, or faculty during my time here. Your commitment of time, expertise, and leadership is awe-inspiring. Most of us who work in the association world are used to the fact that family and friends frequently have no idea what we do. I'm forever grateful that my parents never questioned my initial choice of art history and ancient Near Eastern studies as my major, not something that screamed fruitful career. And when I ended up in nonprofit work and ultimately more than 30 years with professional societies, I'm gonna try not to get upset. My dad would ask me about what I did every day, and I'd explain, and I don't think he ever completely understood what it was, but he'd always say, well, honey, as long as you love what you do. And I can truly say that I have really, really loved working here. So thank you very much.
You got this. Thank you, Eileen. It has been amazing to work with you over the years since you became the CEO of AES. And I think that we see the growth of the society over the last 10 or 11 years and how amazing it's been. And I think everyone will agree with me that it would not have happened without Eileen's leadership. The Distinguished Service Award was established in 1993 and recognizes outstanding service by an AES member in the field of epilepsy, with a special emphasis on exemplary contributions and service to the American Epilepsy Society, its members, and our patients. I am most pleased to present the 2024 AES Distinguished Service Award to Dr. Frances Jensen. Dr. Jensen is the Arthur Knight Asbury Professor of Neurology and Chair of Neurology at the Perelman School of Medicine, University of Pennsylvania, and co-director of the Penn Translational Neuroscience Center. She was formerly Professor of Neurology, Harvard Medical School, and Director of Translational Neuroscience and Senior Neurologist at the Brigham and Women's Hospital and Boston Children's Hospital. After receiving her AB from Smith College and MD from Cornell, she had a neurology residency at the Harvard Longwood program. Her research focuses on mechanisms of epilepsy and the interaction of epilepsy with other disorders such as autism, dementia, and cognitive issues. And she hopes to elucidate new therapies for clinical trial development. She has authored over 175 manuscripts on subjects related to her research and has been continuously funded by NIH since 1987. Dr. Jensen was the recipient of an NIH Director's Pioneer Award in 2007 and a Javits Award in 2020 from NINDS. She was elected as a member of the National Academy of Medicine in 2015 and was the recipient of the Smith College Medal in 2020. Dr. Jensen has trained numerous clinical and basic research fellows who now hold independent faculty positions both nationally and internationally. She has served as president of the American Neurological Association from 2021 through 2023 and was president of the American Epilepsy Society in 2012. She has served on multiple leadership boards, including the Society for Neuroscience and at NIH, and is on the NINDS Advisory Council. Dr. Jensen is a trustee of the Franklin Institute in Philadelphia and is involved in community outreach for brain research and education, and is an advocate for awareness of the adolescent brain and its development, its unique strengths and vulnerabilities, as well as its impact on medical, social, and educational issues unique to teenagers and young adults. She is the author of the book, The Teenage Brain, translated and published in over 25 languages. Dr. Jensen, please join me at the podium to receive this well-deserved honor with our heartfelt thanks for your extraordinary service. Oh, another one more?
Well, thank you very much, Bill. I am really honored to receive this extraordinary award and very grateful for the recognition from my colleagues and from this association. I've really grown with this organization. It's played a central role in my career. And I've been a member since 1989. That's 35 years, I think. And I've been inspired every year of membership. I've been privileged to serve on many councils, committees, program committees, symposia, and obviously the ultimate privilege of being president of this society. And it has been so meaningful to me, and it has been such a privilege to serve. I think what inspires me most about this society is its mission, but also its culture. Its patient centricity, that the individual, community, and global burden of epilepsy is paramount. We learned this when we're working with the Institute on Medicine Epilepsy, report in Epilepsy, which was an extraordinary building moment for our community. And I think it has helped us move forward across many different domains, public health disparities in epilepsy. The intellectual rigor and curiosity of this society applied both to treatment strategies, guidelines, but also basic mechanisms of this vexing disease. And also with a high degree of open-mindedness and open ideas, people talking with each other, thinking outside the box, in both on the clinical side, the research side, and the advocacy side. Collaboration is another distinct trait of this group. Hard problems require lots of collaboration. And we're witnessing an acceleration of advances in population health, translational research, and innovative patient care for our patients with epilepsy. Finally, engagement and advocacy is something that is really extraordinary about this society. Engagement with each other and with our patients, their families, stakeholders in federal entities, private foundations, and also industry. It really does take a village to manage this disease. These are the signature strengths of this organization that I've been so proud to serve over these many years and hope to do more. I remain committed to its success, and I believe with its current leadership, we are poised for many, many great things. Its past leadership, Eileen, it's a little bit of an auspicious moment because it was during my presidency that we decided to go independent, and it resulted in a selection process that brought you into our lives. And just to think how far you've taken this society is I want to thank you personally myself. This is one of the most dynamically changing fields in neurology, but we must stay laser-focused on AES's stated vision to eradicate epilepsy and its consequences. Thank you.
Thank you. Thank you very much, Dr. Jensen, and congratulations. Core to the AES mission is the development of the next generation of basic translational and clinical investigators. These young investigators are the future of our community, and they are a vital part of our society. AES encourages young investigators to attend the annual meeting by providing travel and other awards in recognition of the most outstanding abstract submissions. You can see the listing of these early career investigators in the program book, and I encourage you to visit their posters. In addition, AES supports research through more than $1 million in fellowship and grant awards. An example of the partnership to ensure funding for early career investigators is the AES American Brain Foundation, AAN Epilepsy Foundation, Susan S. Spencer Clinical Research Training Scholarship in Epilepsy. Please join me in recognizing Dr. Dennis Spencer, who will introduce the 2023-2024 awardee.
So it is my pleasure to introduce Dr. Jillian McKee from Children's Hospital of Philadelphia. Her project focuses on deep phenotyping and biomarker discovery for clinical trial readiness in SYNGAP1 related disorders. Please join me in congratulating Dr. McKee on this prestigious award. The Susan S. Spencer Clinical Research Fellowship is made possible by the generous personal gifts of AES members and others who have made contributions to the endowment that supports this fellowship. It only takes a minute to support the Susan S. Spencer Fund, the Lennox and Lombroso Fund, and the Sergievsky Fund for Epilepsy Health, Equity, and Diversity. In fact, if you take out your phone right now and text AES, that's not true. Do not take out your phone. It's not going to work. But the website, go to the website, the AES website, and there you can find directions on supporting and bringing the Susan S. Spencer Fellowship to life. Okay. Now, the seahorse. We bring the seahorse back, year after year. AES has made more of these seahorses, modeled on a seahorse pin that Susan used to wear. And you could not buy these pins anyplace, but you can get one as a thank you for making a pledge of $1,000 per year for 3 years to the Susan S. Spencer Fund. All you need to do is to stop by the member center near the registration if you want to pledge and take home the pin. Thank you in advance for all of you who have or will make contributions to help the AES support the next generation of epilepsy researchers. Thank you.
Thank you very much, Dennis, and congratulations, Dr. McKee, on this recognition for your research efforts. The AES is also proud to be the administrative home, as well as a member of the Epilepsy Leadership Council, a coalition of professional societies, nonprofit patient advocacy organizations, and federal agencies, all working together to expand our impact and improve the lives of people living with epilepsy. I would like to invite Gabby Conacher, chair of the ELC Steering Committee, to come to the podium.
Thank you so much. It's wonderful to be here with you all today. I'm honored to share the stage with many of these epilepsy giants. But essentially, so I'm up here with you today as the chair of the Epilepsy Leadership Council and want to share a little bit about who we are and what we do. First of all, and to thank Dr. Theodore for this introduction and the opportunity as ELC chair to share some brief thoughts with all of you today. As many of you know, the ELC was formed in response to the 2012 IOM report on the epilepsy, which called for an expansion of the Vision 2020 collaborative efforts. So the ELC is working to facilitate a more cohesive community by empowering collaboration between our members to identify and fill gaps in epilepsy support, education, clinical care, and research. We're working on some very exciting initiatives to facilitate the epilepsy community coming together to partner and collaborate. And I encourage everyone to please check out our website, epilepsyleadershipcouncil.org, and see a little bit about the projects that we're working on, because we're filling a very unique space to bring together organizations and government agencies and advocates to really work together to advance care and quality of life for those living with epilepsies. I just want to take 1 second to share. I've been privileged to serve on the ELC for 4 years now, 2 as the vice chair and 2 as the chair. And it's really been an honor to do this work together to improve the lives of those living with epilepsy. I have a son who is 12 and has SCN8A DEE, a very severe form of epilepsy. And this is a really meaningful place for me, the AES itself, and then, of course, the Epilepsy Leadership Council as ways to work together to really advance this work. I'm thankful for the partnership of the incredible patient advocacy groups who have been a part of the ELC. We are a growing community, and we encourage anyone here who's interested in learning more about it to reach out to us. And of course, thankful to AES, who is our organizational home. So thank you. If you see me in the halls, come up and chat with me. I'm happy to tell you more. Thank you very much.
Thank you, Gabby, and to the steering committee for your leadership of ELC. I am now pleased to introduce Dr. Walter Koroshetz, Director of NINDS. Dr. Koroshetz's presence reflects both the long history of strong NINDS support for the epilepsy community, as well as his personal commitment to epilepsy research. And we sincerely appreciate his taking time from a very busy schedule to be here with us again this year.
Great. Thanks, Bill, and it's a pleasure to be here. If I could get the first slide. I wanted to just talk a little bit about what we have been looking at the epilepsy field from the viewpoint of NINDS. And it's always a pleasure to introduce the Hoyer Lecture. There's really no time like the present to look back and look at the champions for epilepsy research, and Judith Hoyer was certainly one of those. She suffered with epilepsy. She devoted her whole career to helping people with epilepsy and also to improve childhood education in Maryland, where she was married to Steny Hoyer, who is the current representative for the 5th District of Maryland, a staunch supporter of NIH and epilepsy research, and who, at the age of 84, won his term in November, so he'll be serving another 2 years. But I would just encourage people to just think back at the power of developing relationships with people who can understand your message about the importance of epilepsy research and make those resources happen. So our mission at NINDS is to understand how the brain, the nervous system works, and then to use that knowledge to reduce the burden of neurological disease for everyone. And so in the epilepsy space, we fund research, and we actually perform research in the intramural program in basic areas of science which can have impact on epilepsy research, sometimes predictable, sometimes not predictable. Also translational research and trying to get new therapies out to patients, and then clinical neuroscience research to inform what works best for what patients with epilepsy. At this point in our history, I think it's really important to emphasize the need to encourage young people to enter the field of epilepsy research. I think that is threatened by a number of different things that are going on. But right now, I think to encourage people and to show them the benefits of working in a community such as AES to try and advance the care of people with epilepsy is such a fulfilling career. And here, we are involved in disseminating the knowledge, all the meetings, all the sessions that you have today, disseminating the knowledge that's been developed by people who treat people with epilepsy, by people who do research, whether it's in animals or peoples or cell culture, and to share the value of that among this community. But it's not enough to keep it in this community. It's really important that we reach out and you talk to your neighbor next door or the person in the Uber to just let people know the value of the research that's occurring in epilepsy, because most people in America probably have no idea what has happened over the last 75 years in epilepsy and how much has benefited, but also how much promise there is for the future. I'm going to talk just briefly about the NINDS budget, when the point to make here is that there is nothing that's going to stop the advancement of science to help find treatments for people with neurological diseases. But the pace of that research, the speed at which it occurs, it oftentimes determined by the amount of resources. So last year, for the first time that I recall, we actually had a cut to the base of the NINDS budget by about $140 million. That, in addition to the inflationary rate and the cost of doing science, really has had unfortunate consequences where we had to reduce the pay line. The percentile of grants that we have money to pay used to be around 14, 15 percentile. Now it's down to about 8 percentile. So we really do need the resources to kind of get the pay line up to a point that it's at least the system can work. This is really semi-crisis mode that we're in right now. There are things that we just can't fund at this point because we don't have the resources. We actually had an epilepsy trial. We wanted to start last year. We just didn't have the funds to do it. So we are hopefully going to put it off to this year and try and gather the funds to do it this year. But these are the kind of tough decisions that we're making at NIH, but you shouldn't feel sorry for us. I mean, it's really the people who are really suffering from this are the investigators and the patients. If you look back over NIH funding for epilepsy, it's been going up each year, and that's a great thing, particularly during the period between 2016 and 2023 when we were getting increases in the budget. But this increase is not really, I think, if you corrected for inflation, it wouldn't be as strong a rise. It might even be pretty flat, actually. So that's the bad news. But I think that it's, we have seen the ups and downs of funding for NIH research over the years. And so I suspect, although we're in a difficult position now, that this will be remedied because the things that we do are just so important and the messages are so powerful. So I just wanted to also mention that at NINDS we valued Eileen Murray's wisdom and hard work. As Bill mentioned, she was on the advisory committee of our council between 2019 and 2022, and she's brought really great perspective and incisive contributions to our institute and as well as to AES. I also wanted to congratulate the Tuberous Sclerosis Alliance, who's celebrating its 50th anniversary. Steve Roberts from the TSA was also a valuable member of the NINDS Council in a similar time frame. And just to note that this was formed in 1974 by 4 mothers from Southern California. So never underestimate the power of a mother. And 4 mothers, wow, that's you can see what happened. But I think you see that in epilepsy all the time as the new genetic forms have been identified. There's a mother who really moves forward that field. And the TSA has done so much good work over the years, as you can see here. I also wanted to mention it's the 50th anniversary of the NINDS Epilepsy Therapy Screening Program. Hard to imagine, but 50 years ago, the idea was to set up multiple different epilepsy models, to open up to industry, academics, bring in their assets, test them in these models in a very kind of informative and rigorous fashion. And over the years, it's led to the commercialization of multiple different agents. And next, I wanted to mention that Dr. Ann Padori was so excited has come on as a deputy director for NINDS. So hopefully, in ensuing years, this talk will be given by a real epilepsy expert, not by an imposter like me. But Ann has been a fantastic epileptologist at Boston Children's Hospital and a researcher, particularly in the area of genetic research. Now, over the last year, there's been tremendous progress in epilepsy, multiple different high-profile papers. We had the MONIAD study, which looked at the effect of anticonvulsants, but now looked at 6 years of after the children were exposed to anticonvulsants in mothers with epilepsy. And certainly there are drugs like lamotrigine and loracetam that are very safe, and also the finding, which not too surprising, but that high folate was really associated with better outcomes. The Center Without Walls program that NINDS funds are major projects around the country to make advances in particular areas of epilepsy, particularly in the genetics. The first two were in genetics. We found a lot of genetic mutations that give rise to epilepsy. And then we have two more CWOWs that are looking at the mechanisms for one, the channel-associated epilepsy, and the other, the non-channel-associated epilepsy. And then we also had work which I think was really earth-shattering and groundbreaking in the field of sudden unexplained death in epilepsy. So the work continues. This is a paper that came out now looking at over 20,000 individuals with epilepsy, looking at the genetic mutations. And the common theme that comes out is that a lot of these ion channel receptor mutations are common to multiple types of epilepsies, but then the other gene disorders seem to be more specific for the different types of epilepsy. People have been able to go after these genes. These are the sodium channel mutations in one of the CWOWs under Al George. And so they've been able to actually look with automatic patch clamping. I spent many, many hours trying to manually patch clamp. It's hard to imagine you can do it automatically, but you can, and you can get amazing data. And you can see, what the mutations are actually doing to the neuron. And in the second paper, the nuance is that in development, there are different splice variants of these sodium mutations. And so the mutations, actually, you have to look not only, particularly in the developmental phase, not just look at the adult isoform and what it does, but also in the developmental isoform. And in the area of SUDEP, the group headed by Sam Latou has a paper showing that in people who have, in monitoring conditions, EKG showing exaggerated sinus arrhythmia and bradycardia seem to be most enriched in the folks who have actually died due to SUDEP in the follow-up periods. So a way of potentially identifying that risk population to help us do something about that. I'm going to end on the finding of two anti-epileptogenesis ideas, which I think are kind of the holy grail. You have a seizure, that doesn't mean you have epilepsy. You have epilepsy when you continue to have seizures. So is there a way to start from the first seizure and prevent epilepsy from occurring? So this is a paper that I think this one is still in bioarchives, if I remember right, showing that inhibition of this JAK-STAT pathway, although it has some effects in the early stages of epilepsy, the big effects are, weeks later, or sometimes really months later. So you can actually look, and so in this, you start this epilepsy with canic acid, you wait 8 weeks, 3 weeks of vehicle, and then you treat with the JAK-STAT inhibitor, which is an FDA-approved drug for rheumatoid arthritis, and you see a big drop in the seizures, even at this long time period, even actually out to a couple of months in these experiments, where you see here's the treated in the red and the untreated in the black. So really prominent effects on development of epilepsy after an episode of status. Another very similar idea is coming out of the work looking at the lymphatics, which are the CSF flow along blood vessels out into the spinal fluid and into the lymph systems. A lot of the flow comes through aquaporin channels in the end feet of astrocytes around the blood vessels. And what these groups found is that if you can improve the lymphatic flow, you can actually have an effect on anti-epileptogenesis. You do that by blocking adrenergic receptors, all different types of adrenergic receptors that enhances the lymphatic flow. You see very little effect in the early phase of this, but then in the late phase, you see a big drop. The dark purple is almost disappearing here many hours after the canic acid. And then even weeks later, you can see an effect of increasing the lymphatic flow on dropping the seizure frequency. And here with the vehicle, the animals have really abnormal behavior compared to the sham, but the treatment actually gets their motor behavior really back towards normal, as well as improving survival. So I think we've now have a glimpse of how we can actually get at this anti-epileptogenesis after a seizure, try and treat to prevent further seizures. I wanted to mention that in 2025, NINDS is also going to be reaching its 75th anniversary, and just thinking back, as Bill mentioned, about the integration ties between NINDS and the Epilepsy Society, just to point out that in the early days, the director of NINDS, both Pierce Bailey and Richard Maslin, were also presidents of AES. Kiffin Penry, prominent epilepsy researcher, started out at NINDS and then became president of AES. Roger Porter, similarly, and now Bill Theodore. So the ties continue, and we really appreciate it. And now I just wanted to mention it's really a pleasure to hear from Edward Hogan, a really expert clinician who's been studying different pharmacological treatments for epilepsy, how these can be informed by imaging. And he was a past president. He's going to talk about the past, present, and future of treating seizure patterns. And with that, I think we can hand off to the video from Representative Steny Hoyer from the state of Maryland, the representative of the 5th District. Thank you.
Hello, I'm Steny Hoyer, Congressman from Maryland's 5th District and the former Majority Leader of the House of Representatives. Welcome to the American Epilepsy Society 2024 annual meeting. My late wife, Judy, lived with epilepsy, so I know all too well the challenges that can come with that diagnosis, but also all that is possible while living with epilepsy. Indeed, this lecture itself is an example of what Judy was able to accomplish in the face of her diagnosis. The AES annual meeting brings together epilepsy professionals in academia, clinical practice, industry, and advocacy from across America and around the world. Crucially, the annual meeting helps ensure that we keep making progress to understand, treat, and yes, even cure the epilepsies. We each have our own part to play in that shared mission. Year after year, we're fortunate to have many patient-centered epilepsy organizations collaborate with us on our shared goals. I thank AES for continuing to elevate the voices of people with epilepsy and their caretakers at the annual meeting and beyond. AES remains one of the largest and most influential nonprofit funders of epilepsy research, working with its partners to award over $1 million each year to early career and established researchers. As always, I also want to thank Dr. Koroshetz for his leadership at the National Institute of Neurological Disorders and Stroke, which continues to spearhead groundbreaking epilepsy research and initiatives. Please know that I continue to do my part here on Capitol Hill. This past year, we made important progress here in Congress to support epilepsy research, programs, and services for those living with the condition. Under the leadership of co-chairs Dr. Greg Murphy and Jim Costa, we grew the newly established Congressional Epilepsy Caucus to 52 bipartisan members. This year, Senators Amy Klobuchar and Eric Schmidt launched the Epilepsy Caucus in the Senate. Our bipartisan, bicameral caucus is standing up for the people living with epilepsy throughout the legislative process, especially through our annual appropriations. We successfully secured $11 million in funding for the CDC epilepsy program in fiscal year 2024, as well as $25 million for the VA Epilepsy Centers of Excellence, an increase of $6 million. We made progress this past year, but much work remains. We need to secure further funding for key research entities, including the BRAIN Initiative and All of Us research program. This year, our Epilepsy Caucus co-chairs also started working on legislation to authorize a national plan for epilepsy. The bill will renew and increase much needed attention on the epilepsies and help us come up with new solutions to expand access to care, advance research, eliminate health disparities, and prevent epilepsy-related mortality. We need all hands on deck, not only members of Congress, but patients, caretakers, medical professionals, and other advocates to get this bill across the finish line. We need you to keep sharing your stories and making your voices heard so that we can build on the progress we've made this past year. Maintaining our momentum depends on leaders like our keynote speaker today, Dr. R. Edward Hogan. Dr. Hogan is a professor in the Department of Neurology at Washington University in St. Louis and the director of the Comprehensive Epilepsy Center at Barnes Jewish Hospital. He is also president emeritus of the American Epilepsy Society. Dr. Hogan's research focuses on the pharmacology and clinical use of anti-epileptic medications, as well as neuroimaging changes in patients with epileptic seizures. Through his clinical and research efforts, he aims both to provide and improve medical and surgical treatment of epileptic seizures. I'm sure you'll find his lecture both insightful and, yes, inspiring. How proud Judy would be to see all that the epilepsy community has accomplished this past year. I know the lecture and the annual meeting will only renew our determination to advance our shared mission even further. Thank you, and Godspeed.
Well, thanks, everyone. Certainly, it's a real honor to get to give the Hoyer Lecture this year. And Walter, many thanks for the introduction, as well as Senator Hoyer. So it's very nice to be here. I will speak about treating seizure patterns, past, present, and future. My disclosures, some of the products that are made by these companies will be discussed today. The ones that are mentioned, I'll be careful to stay within FDA indications for their discussion. So these are learning objectives. Those are in the program. You can take a look. I'd like to give an overview. I'd like to talk about seizure patterns. First of all, talking about the history. There's a long history and interest in seizure patterns, and we'll go over those past observations and treatments and develops. Then we're going to jump to the present. I'm going to define the present as when I started to practice. All right? So present is relative. So about the mid-90s is the present in my definition. And during that time, it's been really fantastic to be involved with this topic and seeing how it's evolved, both with current therapies, with acute repetitive seizures. And those are our main therapies now, and they're available in several different dosage forms that I'll discuss in detail. And then finally, a little bit about the future. Where do we go from here? I'm really excited about some of the possibilities we can use to develop new treatments for epilepsy. We're going to focus a little bit on additional treatments for acute seizures, as well as better prediction methods for seizures that are under development. Okay, we'll start with the past. So looking over the literature, this was the oldest reference I could find, talking about seizure patterns. Those of you that are brushed up on your cuneiform text from the Babylonian era can read this directly if they'd like. For the rest of us, fortunately, there's a translation that was made by Wilson and Reynolds in 1990. And I do recommend reading the translation. I think it's very interesting. I have taken one quote from this, and there are some different things that they talked about. This was made in the middle of the 1st century BC, so about 2,500 years ago. And one of the quotes from this was, "If he has a fit 2 or 3 times during the day, if he is flushed in the morning and pale in the evening, it is MIC2." And my understanding that MIC2 is a rough estimation of what we call epilepsy today. So this is one of the first written definitions of why seizure patterns occur. I'm going to skip a few years to the more contemporary reference from Gower's textbook in epilepsy. He did have a chapter in that textbook in 1885 talking about the course of epilepsy. And so he defines, I think, more precisely what we think of about these seizure patterns and groups of seizures. So he calls these groups of attacks. He goes, the attacks may be isolated or grouped. The former is more common, but the later is not infrequent. At periods which vary from 1 week to several months, several series of fits occur, separated by intervals of a few hours, sometimes of a day. So people have been thinking about patterns for a long time. I think it naturally, from etiology perspectives, kind of brings up curiosity as to why these occur. And so there's a long history of this in the past. But I think when things really changed and it became much more relevant was when we started to develop some real treatments that could really change the course of these patterns of seizures. And so I'm really going to focus on that treatment history. And I think a real landmark in the treatment history for periodic seizures was the development of diazepam. So diazepam was first clinically introduced in 1993, primarily used as a sedative. It didn't take long for people to understand how efficacious it would be in the treatment of acute seizures. So initial IV formulations were quickly studied for epilepsy and then other dosage forms. And I think there's this long-held, saying that I think makes sense, is that the best way to know how well a medicine works is how long does it stay in clinical use. And diazepam was one of the first medicines introduced. It still remains a first-line medication for treatment of acute seizures, whereas some of its other indications as a mood-altering agent have really kind of waned over the years. So there are a lot of great benzodiazepines for status and acute seizures, but I think diazepam really illustrates how benzodiazepine as a whole have been just a fantastic agent for this treatment. So a little background of how did this come around. The first initial publications for intravenous diazepam for status epilepticus for prolonged seizure activity occurred in the mid-60s. Some of the giants in epilepsy wrote these papers, Gusteau, Cesare Lombroso. So these were, the leaders in epilepsy really took on the study of diazepam initially. I'll give a few quotes here to understand, the impact that the diazepam had as an available treatment at the time. So Gusteau is quoted in his article as, "Our results show diazepam to have an effective, one might say spectacularly effective action on spontaneous epileptic seizures, which develop into status epilepticus." And also says that diazepam, in our opinion, is the drug of choice for emergency treatment of all cases of status epilepticus. So this is a real landmark that people recognized really changed what maybe we could do acutely at the time for intermittent treatment of acute seizures. And then I'd also like to talk a little bit about Cesare Lombroso. Cesare was also a past AES president. And he talked a little bit about the definition of status in his article about diazepam back in 1966. And what he says is the definition of status epilepticus includes not only generalized and partial convulsive states, but also petit mal and absence status. This definition might be confused with serial epilepsy, which attacks are frequent and the condition lasting, but where recovery of consciousness between attacks represents an important difference. Right? So I think even back when we have these initial treatments on board, I'd like to think maybe Cesare was thinking, okay, we have status, but we have these other treatments where maybe diazepam could be really useful for treatment. And this idea of how you sort that out, how you think about it, is still a really important issue today. I think maybe serial epilepsy would be another word for cluster seizures or acute repetitive seizures. And his next quote was, while an all-inclusive definition may have theoretical justifications, clinically and therapeutically, there's a vast difference between epilepsy partialis continua and convulsive status epilepticus. So again, I like to think he was thinking about the shades of gray, right? How do we use these definitions? How do we make those definitions kind of on the ground that really help treat patients, right? Because there's a lot of difference between these acute seizures, how they're treated. And I'll show another study later on that I think this was on Cesare's mind as he went forward to treat acute seizures more in an outpatient setting. So rectal diazepam was looked at carefully probably about a decade later in the mid-70s to early 80s. I'll show one of these, so one slide here. I like pharmacokinetic curves, so you're going to have to live through a few of these during the lecture. But what happens with this, we test these medications, we see how fast they get in, right? And it's a good surrogate measure of how well they're going to work. So early on, this idea about using rectal diazepam was important, and so this is an early study. It's looking at diazepam solution and diazepam suppository, and we can see it was very quickly found out that the suppository is absorbed much more slowly, and that the solution absorbed is relatively rapidly, especially in this paper. But the idea, if you want to get a medication in quickly for acute seizures, rectal diazepam solution is better than diazepam suppository. So circling back to Cesare Lombroso, his early paper on use of diazepam was really early in his career. This is later. Again, I'd like to think that he was thinking this out and had an idea that diazepam would have uses besides just status, but also in other areas as well. And he did publish a paper in 1989 where he looked at intermittent home treatment of status and clusters of seizures with rectal diazepam. And with these patients, he called these severe epileptic syndromes, and we'd call these epileptic encephalopathies now. And he said that despite appropriate therapies, still had frequent, bad seizures. Most of the subjects were children, which is what usually happens with these cases, with these studies, which I'll discuss in more detail because this is very, very common in young children. I think maybe a few adults from Cesare's practice might have leaked into the study cohort here that graduated from his pediatric practice. And basically what he did is this was a time when they became able to use rectal diazepam. So they looked at what happened before the use of rectal diazepam and after. And so an initial open trial to discuss this. And what I'll just highlight, a couple of the results here. So if you look at the top line here, you can see this was without intermittent home use of diazepam. What they found in these patients with what they called status non-convulsivus at the time was that 71 or 83% of these patients before treatment would have seizures between 1 to 6 hours. And what they found with the home intermittent use of diazepam is that number came way down. So still not ideal, but obviously would look to make a big impact where only 16.5% of these patients had prolonged seizures, and similar results with the earlier time points. So I think he had an interest in this and studied it later on. I'd like to give a shout out to Jim Cloyd. Jim is a really good friend. He's been a great colleague of mine over the years at AES. He's got a great expertise in this area, and he especially gave me some insights on the early Norwegian experience with rectal diazepam. They got an early start with this, and Jim has been was very involved in the development of rectal diazepam and treatment of cluster seizures and ARS. And so Jim really clued me into this and gave me some really helpful articles to put this part of the talk together. So I think this is worth talking about because this early Norwegian experience with rectal diazepam came about because they were able to get a regulated formulation of rectal diazepam available in Norway in 1979. So this was relatively early. This is really when people were starting to look at rectal diazepam. And this really responded to an on-the-ground need, right? It'd be great if we had all these patients with bad seizures in the emergency room all the time. But these patients, that's not possible, especially in rural settings. This idea to have an available treatment for acute seizures is really important and needed. So they brought that to the fore. This was kind of a 20-year update of their experience, and so you can see that the use of rectal diazepam is defined by daily doses, is relatively stable during that time. And I want to make this point about most of these formulations of benzodiazepines and benzodiazepines as a whole, is they're usually very, very well tolerated. Right? So the morbidities for these medications is really low. So we want to make sure we use them appropriately. So a few things that they brought up just from their clinical experience, and I think this still bears a lot today with how we should treat patients for acute repetitive seizures. One is that it's really their use of rectal diazepam was important in children, but just the whole idea of acute repetitive seizures is much more relevant in children because of the prevalence there, and we'll talk about that. The other thing, and I'll let you read the quote, I'll just paraphrase, I think this is a really important point for patient care, is that one of the things that patients say is the hardest thing for them is the unpredictability of having a seizure, that they can go somewhere and they don't know at any time, anywhere, this seizure could just come on. And especially the dynamics with families, where you have families that are taking care of those children and don't have any available treatments, that the idea of having a treatment, like in this case, use of rectal diazepam, made a big difference. And I think there's dynamics in families, but also for adult patients to have this available if they have prolonged seizures really gives them a sense of control, and I think is really important for treatment. Excuse me, went the wrong way there. So one other clinical point that they brought up that I think is quite important is how often do we use these medications for them to be effective, right? We know that there can be accommodation of the effects of benzodiazepines, and I'm good to use good clinical experience to figure that out. The idea here was that, from the Norwegian experience, the idea was that you should use these no more than 2 times a week. Right? And so we have some more relevant later data that I'll talk about with this. And then finally, there's a judgment with this, right? You have to make sure that you use the benzodiazepines for severe seizures, so there has to be some kind of clinical way to figure that out. And then also, unfortunately, there's the risk of abuse. And so it can be overused, and then you get into the concerns of whether there might be withdrawal seizures or otherwise. So all those important issues were on the table back with this early experience. So up to this point, we had really strong clinical evidence that this effectiveness of rectal diazepam for acute seizures, but there's a couple of things that are really missing. One was there really needed to be a standard rectal diazepam formulation to treat these seizures effectively. And then the other thing is there were a lot of open label trials, but there weren't any really great controlled trials to really prove this concept could be treated. So this was remedied by a couple of papers in the late 90s. First one, this is first author Jim Cloyd. Jim played a really huge role in the development of rectal diazepam, really did a fantastic job with this. And he had a study looking at the comparison of pharmacokinetics and cognitive effects of diazepam rectal gel with IV diazepam, and found that the bioavailability was quite good at 90% compared to IV formulation. Also, again, I'll make this comment quite a bit, is that there are only mild alterations in cognition, and these went away in 4 hours. So these medicines are really safe, especially given in this form. And because of their initial results, there's no need to do a toxicology study afterwards to verify the safety of the use of rectal diazepam. And again, one of my favorites, you have a few more of these to endure in the lecture, but here's the pharmacokinetics of what you get with different forms of diazepam. Again, with the idea, this would give you some idea of when they'll work after you give them. IV form typically is absorbed in minutes and then dissipates over hours with lower concentrations as it goes on. I like to think with rectal diazepam, I like to round off with this. I think that the Tmax, of the time that it reaches maximal concentration, is about an hour. All right, so you can think about how its effects might take place based on that. And then this was really a landmark article in acute repetitive seizures. This was published in the New England Journal by Fritz Dreyfuss and others. And this was a really nicely designed randomized, double-blind, parallel group, placebo-controlled trial. And what they did is they defined cluster seizures as multiple complex partial or generalized seizures, and there was a little bit different between pediatric and adults. For adults, it was they defined that the period of time that you would have a cluster to be 24 hours, whereas in children it was for 12 hours. So the idea behind this is there has to be some clue that from that initial seizure that someone has, a clinical clue, it can be the pattern of the seizure or post-ictal findings, that they're going to have another seizure within this specified time, right? And that's the trick for this, to know the right seizures to treat. And so that's essentially what they did in this trial, and they worked with a caregiver or parent to define those seizures that would be more likely to show, to repeat as acute repetitive seizure. And the trial showed that this treatment is efficacious. It was the first double-blind placebo-controlled trial we have for this. But essentially what they did is they treated seizures as defined, and they followed patients for 24 hours in adults, as according to their definition, and 12 hours in children, looking for recurrent seizures after treatment. And with this, what they found, a reduced seizure frequency. The other thing that's really been important with this is that treating these seizures really just helps patients in general with global assessments, right? So, of course, there are going to be some sedation from the medicines themselves, but almost always, if a seizure is avoided, the overall outcome for the patient is better. So patients do better, and this was an improved global assessment scale in this trial. There was some somnolence, but again, no respiratory depression. These medications are very safe and should be used appropriately. Okay, well, we'll go to the present. I will tell you that very early in my career, I read that article by the first author, is Fritz Dreyfuss, and that made a real impact on me. You know, I mean, I thought, this is like really cool. So you can do this intermittently. And so I've been really lucky with that. So that's where we get to the present, because that's when I started to do this, you know, for what it's worth. But it's been really great that I had a chance to really see this field grow and essentially treat patients in this way. I think it's quite helpful. So what's going on with the present now? What do we know? We have this historical background, and what's gone on during more contemporary times. So first of all, let's quickly go over the definition of status epilepticus. I think most of us know this definition. The idea is that someone has a seizure for 30 minutes, and it's either a continuous epileptic seizure or you have 2 or more seizures without recovery of awareness or consciousness between the seizures. There was a recent task force with a paper led by Eugen Trika, where they expounded on it a little bit, and they included these T1 and T2 definitions. T1 is the idea that you need to initiate treatment within 5 minutes of seizure onset, if at all possible. That's the first goal. And T2, that at 30 minutes or longer, you can typically see, unfortunately, long-term consequences from the seizures themselves. So how about the definitions of ARS? And I think the complexity of this has to do with individuality of patients and how this can be different, right? We don't really have a standard definition of ARS, and we'll talk about whether it's a good thing or a bad thing or not at this point. But these are some definitions from clinical trials, and I think it reflects the clinical situation that people are in, right? So, and so I'll go through a few of these. One definition, this is from the trial of intranasal midazolam. What they defined this as being 2 or greater seizures, focal or generalized, that occurred at least 10 minutes apart, occurring within 6 hours. So that's how they did the trial, using that criteria. There's other criteria. Cheryl Hout did a nice study in 2002 where she used a criteria of 3 seizures within 24 hours. It's commonly used, the general term. In the EMU, patients tend to have a lot more seizures, right? So in this study by Rose, there are at least 3 seizures in 4 hours. So very different definition there. And then finally, catamenial pattern of seizures is it's a different concept, isn't it? Because you're comparing 2 time periods. So this study by Herzog in 2004, it showed they defined this as a 3-fold or greater number of seizures during the perimenstrual period compared to the baseline outside of that time. So in that way, you're looking at different time periods and an increase overall. So there's ways to define this, and depends what data you're looking at. And we'll expound on that a little bit more. But I think this just reflects the complexity of the clinical situation we're working with. So that's our definition. What about prevalence? You know, I different feelings about this. Most of my pediatric colleagues say, oh yeah, these are really bad, you know, and most of my adult colleagues say, I never see this kind of thing, you know, so it varies. I think also I'll go over some of the data on this. Certainly happens a lot more in children, and we'll show what we have. I think this was the best cohort study we have looking at the prevalence of acute repetitive seizures. This was used in a UK general practice research database looking at the calendar year 2005. And what they did with this, they typically the main criteria they used was 3 seizures a day, 3 seizures or more a day in their chart review to look at this. They excluded myoclonic unresponse epilepsy. And their general prevalence they found in the general population was 2.3 per 10,000, and their age-adjusted prevalence was 2.5. That was the numbers. The thing that really comes out in all these trials, and this is why pediatric neurologists are, you know, usually right on top of this, and we do our best as adult neurologists to keep up, is that nearly half of the patients that in their review were patients what were called at the time this catastrophic epilepsy syndromes of childhood. I think these would be called epileptic encephalopathies now. So that group is particularly at risk for prolonged repetitive seizures. And this is just graph form. We're looking at the prevalence and just shows this trend, which is very high in young children. It usually comes down as people kind of reach early adulthood. And you know, I will say I've seen plenty of adults with ARS, so it does happen in adults, but not as commonly, and less so as people age. The other really important thing about prevalence is with any epidemiologic principle, it depends on the population you look at as to how often you see a phenomenon, right? And so this is a general trend. If you look at a general population, if you look for severe seizures, they tend to be a lot less. But if you look at a more referred population or tertiary care population, you know, those severe seizures will be a lot worse. And I think that's what we really find here in this review. This is a nice review that was lead author was Steve Chung. It was published in 2021. And what he did a really nice review looking at different studies that came up with a prevalence of acute repetitive seizures. You can see the very lowest one was the study I went over in detail, the study of Martinez in 2009 from the UK. But it came to much higher studies depending on what the practice setting is, right? And this makes a lot of sense for me. This was what Steve and colleagues came up with, was that overall there's general lower prevalence in community care settings, but in tertiary care centers such as epilepsy centers and hospitals that it was a lot higher. And so a lot of us work in tertiary care centers, so you need to be on a high lookout for these because they're relatively common. So that's kind of what we've learned about some of the epidemiology and definitions of ARS recently. I would like to talk a little bit about some of the new treatments now. I want to just take a quick step back. I've talked a lot about diazepam so far because historically it's such an important driver, I think, in developing some of the ideas of treatment and definitions for ARS. But we have a lot of benzodiazepines now. And a lot of these are listed here. There's been many trials that we've done with many different benzodiazepines. There's really not an exhaustive list here. This is a nice review by Cheryl Hout, who's done a lot of really fantastic work in this area. And Cheryl did a nice review, looked at all the trials that have been done looking for acute seizures in general. So a lot of different benzodiazepines, many different routes of administration have been studied. Right? So there's lots of ways this can be done. And her general conclusion with this was that we have a lot of investigational formulations, some of which have much been more precisely studied than others. But in general, it looks like all the benzodiazepines have a favorable impact on ARS and prevention of seizure recurrence. Some just aren't studied as well as others. And so we'll have to see how that works out. I'm going to focus on a few of them here, but there's a wide range of studies and a number of benzodiazepines that probably work for ARS. So I'm going to focus on the intranasal delivery of benzodiazepines, since we have some more recent development of those compounds. Intranasal route really as a more practical pathway to give treatment for ARS in an outpatient setting, right? To give these medicines outside the hospital is difficult. We can't start IVs. We have to find a different way to do this. And so intranasal has been a really attractive way to make this happen. I'll show some studies that show that intranasal delivery of benzos provides reliable pharmacokinetics, very important for treatment. And we have some relatively recent approvals from the FDA for intranasal midazolam in May of 2019 and intranasal diazepam in 2020. Okay, so you get some more pharmacokinetic curves here. And again, these are, I think, general guidelines for when you think these medicines would work. This is a pharmacokinetic curve on the left for intranasal diazepam. This is a pharmacokinetic curve, to my right anyway, for midazolam. And I'll go over each of these briefly. This study, these are how these phase 1 studies, these are typically phase 1 studies. People come in, they get the medication, they're measured over time to try to show equivalence or not between different formulations in these scenarios. What you see here on the red line here, this is a pharmacokinetic curve for intranasal diazepam. You can see that I like to think that this formulation that has a Tmax of about an hour, so it maximally gets in over about an hour's worth of time. The comparison in this trial was in patients, this is oral diazepam, this is rectal diazepam. All right? And at the end of the day, the FDA came to the conclusion that these were equivalent dosage forms. This is how this is essentially how rectal diazepam, or excuse me, intranasal diazepam was approved as a comparison to rectal diazepam. And then how about midazolam? Well, here's the curves again. Again, different forms of administration. At the end of the day, the approved dosage form of midazolam was the 5 milligram dosage size, and so I'll outline the graph with the arrow. You can see there's a difference, right? The Tmax for this formulation is about 10 minutes, so its Tmax is quite a bit earlier. So it has implications. Also, if you look at this relative to at least for Tmax, for IV, that the intranasal form got in just about as fast as the IV did in this pharmacokinetic trial. So interesting differences and implications in how we treat patients with these two agents. I'll also add to say we have no direct clinical and comparative trials between these. So the pharmacokinetic data is what we have to make decisions. So those are a couple of new agents. There's some things that have opened up with this. And so one thing is we have more studies, right? We have more rigorous studies with these compounds. So one question I've always had over the years, how often can we really give these? I already mentioned before from the Norwegian experience, they say a couple of times a week. And so now we have more data. I talked to Jim Cloyd about this. Jim's a pretty good guy to fall back on to look over this stuff. And so Jim took this on. He also got Lindsay Garrett involved, one of his PharmD students. And what they looked at was this idea, what clinically do we have to say, what is the really acute benzodiazepine tolerance and acute repetitive seizures? So it's really how often can we give this before you give it so much that you get accommodation and then you stop it and they start having seizures. So we have more data. They did a really nice review for this. I really want to give them a shout out for the help. And we really looked through clinical trials for FDA-approved medications. These were rectal and intranasal diazepam and intranasal midazolam. And we found quite a few good articles. In the interest of time, I'm going to focus on one study on intranasal diazepam. But we're showing, getting more data to know how to use these medications. And of course, there's indications from their FDA approval. So this is this I'm going to talk about essentially the lack of tolerance of intranasal diazepam for ARS. This was a nice phase 3 open-label trial where they looked at repeated doses of intranasal diazepam. This was published as the lead author with Greg Casino in 2021. And they looked at a proportion of patients that had been in the trial for at least 12 months. And they also, to know how did they define use of the medication, was that the first dose was administered at event onset for the clinical indication for the trial. And the second dose could be given again 4 to 12 hours later. So there could be 2 doses given, kind of for an acute episode. After that was done, though, there was a maximum of 5 days required between treatments. So this was kind of, you give a couple of doses and you had a 5-day gap. So that was how often they gave it. And what they did was that the patients that had been in the trial for at least 12 months, they divided out the early part of each person's experience compared to the last part. So they split it in half, an early part and the last half. And they compared those two to see if there were any significant trends of increased use, with the idea that there was a tolerance that patients would have to use the medicine more. And essentially what they showed was no consistent trend using, for the second doses, you have to use it twice for one episode, or an increased overall use over the two time periods. So better evidence to say that we really, if you're using it by those guidelines, a couple of doses, in this study, at least 5 days apart, there's no evidence that there's any tolerance of the dose itself. Pretty close to the Norwegian experience of a couple of times a week. And so we're getting more specific data to know how to use these medications. Okay. I'd like to cover one other intranasal trial in a little more detail. And in this one, I'd really like to give a shout out to Mark Halverson. I was an investigator on this trial. These trials are really hard to do. They're done as an outpatient. It takes a lot of commitment to the organizers of these trials to make them happen. And this was really Mark's baby. I remember working with him on this, and it was really a lot of his sweat that made it come out at the end of the day. And I'd also just, he's been such a great AES member over the years. So I want to give him some recognition for that. And really, just for a second, it's been a real privilege during my time at AES to work with a lot of PharmDs. I've shouted out a few PharmDs that are relevant to this topic. But the AES is fantastic, and then we have these people with fantastic expertise in a lot of different areas. And I've really reaped a lot of benefits from being able to work with that group as a whole. And I think it's one example of just the multidisciplinary effort we have for epilepsy and AES. It's really fantastic. So this was certainly an example of that. So Mark was very involved with this, and this was a really nice phase 3 randomized controlled trial where they looked at intranasal midazolam, in 134 patients, 67 patients with placebo. They did find at the end of the day that midazolam was more efficacious as compared to placebo, and about 54% in the midazolam group, 35% about in the placebo group. And again, I want to put it out there, these medications are safe, all right? In the double-blind treatment phase of this, no patient experienced any acute respiratory depression, and nobody had any really significant adverse events. I would like to say with this, if you had to read a trial, the Dreyfus trial is probably the landmark trial for acute repetitive seizures. This article would be number 2. I think it's a really helpful, really well-done trial. A lot of important things they looked at about acute repetitive seizures. I'm not going to go over a lot of details, but I do want to just make one point, which I think was really interesting in this trial design. So there's always this idea that if you give the medication for the acute seizure, is there any benefit for that, all right? And this is hard to test in clinical trials because there's natural variability in the length of a seizure anyway. So it's really important to have a good control group to figure this out. And so in this trial, it was set up that way. So it was set up that you'd give the first dose of midazolam, and then if there was still a seizure, then you'd give a second dose. You could give a second dose, right? So, that was the clinical trial design. And they had a placebo arm. So basically, you're able to test, whether somebody got the medicine or if they had a placebo treatment, if the seizure stopped within 10 minutes, right? So, which is kind of what we'd love to have, right? Something as an outpatient that would stop the seizure right away. And what they found was that this was 80% of patients treated with midazolam had seizure termination in 10 minutes. 70% in the placebo group. This was not statistically different. So we're not making a huge dent. And you thought it might, because the Tmax for this medication is about 10 minutes, so it kind of makes sense it might work in that time period. But I think in general, to make the point about this, we're treating clusters of seizures or repetitive seizures with these medications, not acute seizures, right? It doesn't get in fast enough. But it can be quite helpful. It's been shown in multiple clinical trials. So this takes me to my next point, which is this new outpatient work group that just came together. This was Outpatient Management of Prolonged Seizures Work Group. This is a newly published guideline in epileptic disorders just earlier this year. And with this work group, they came up with this term for rapid and early seizure termination, or REST medication. So what's the ideal medication to be used in an outpatient setting? And there were strong recommendations that a good REST medication would be one that would start to act within 2 minutes of administration to terminate ongoing seizure activity, right? So, this idea to get something really fast and make a difference and have it be safe enough in an outpatient setting would be a really good breakthrough. And so I'll jump into the future a little bit here. So this is not a clinical available medication yet, but it's interesting, a medication in development. This is inhaled alprazolam. So this is a formulation of alprazolam and a device that's you're able to take an inhalation of the medication. There are 2 recent phase 1 pharmacokinetic studies looking at this. It showed that alprazolam was rapidly absorbed using their device, and the Tmax was pretty short, 1.5 to 2 minutes. And again, I'm going to make this point again. These are well-tolerated medications that should be used, for effectively for seizures. And here's a pharmacokinetic curve. I think this is the last one. So if you've made it this far, you'll make it to the end of the lecture. All right. So this is with these phase 1 trials, you have to compare different patient groups to see how that might affect absorption of the medicine. So in this phase 1 trial, they again gave the patients medications, tracked concentrations afterwards. This was looking at smokers and non-smokers, and what you can see is that the peak concentration of the medicine is within 2 minutes or earlier. 2 minutes was the first time the concentration was measured, and it was thought in both of these groups these would be therapeutic doses for treatment of seizures. So this medicine gets in really fast. You might wonder why the smokers did better, and the speculation is they're good at inhaling. And so, not to promote smoking, but in this case, it's a good thing, I guess. So that's again, a proof of concept that this medicine might really be very interesting how it works out. There's been a phase 2 and an ongoing phase 3 trial looking for its use in acute seizures, and it'll be really interesting to see how that comes out. Might be the next step for use of benzodiazepines. Okay, well, I've gone through the past and tried to give an overview of the present, but what goes on in the future? What are some things that could happen going forward? And so I'm going to go over a few things that might be in the cards, and it's always kind of fun, so we can speculate a little bit as to what might happen. I would like to highlight a really nice program that was put on by the NINDS back early last year. And the idea was looking at status epilepticus after benzodiazepines. I think I've already made a pretty good case that benzodiazepines are pretty good medications, but they're not perfect, right? We can do better. And so that was what this conference was really all about. There's a really fantastic group of lectures. This is still available online for people, so I really encourage you to look and take a look at what's there. But I am going to focus on one part of one subject that was covered, pretty well during that presentation, and this is the use of ketamine. So, ketamine, I have to say, in my experience, I really haven't used it that much. It's kind of, people with really bad status, I've used it a couple of times, but use it in anesthesia and things like that. But I think it's got some really interesting implications that might make it a really fantastic medication for acute seizures. So, when we think about this, when we think about new medications, the first thing we do is look to our basic scientists, right? About what are the things that are going on? What are the medicines that might be the next steps to help add on some different alternatives from benzos for treatment of acute seizures? So benzos work by a GABA mechanism. It makes a lot of sense that NMDA receptor antagonists would be really great candidate drugs, as complementary medicines for treatment of status, which is the case for ketamine. There's been some data out there that's I think very interesting. This is a study by Martin and Kapoor back from 2008, where they used a combination of ketamine and diazepam, and they showed that it synergistically controlled prolonged status epilepticus in an animal model of epilepsy. Also, interestingly, there's a lot of preclinical study data, the use of ketamine for chemically induced status epilepticus in rodents, and shows it's remarkably neuroprotective. So these two things, a complementary action to stop seizures and the idea that these medications can be neuroprotective, I think make this a really great candidate for the next steps to maybe be the next step of what we'd use for a clinical trial. And then what are we using ketamine for now? And interestingly, there are several uses for ketamine. And again, this is not a medicine I use a lot, but looking through the literature, I found some interesting ways it is used. First, I think all of us know that it's used as a dissociative anesthetic. It has a relatively short duration of action. But one thing that's interesting about it, it generally maintains airway reflexes and respiratory drive. So this idea that it could be used to treat status without needing intubation is very attractive and might have applications, maybe without, outside the emergency setting. The other thing about ketamine is I didn't realize that it's used so much in emergency departments already. So it's used quite a bit. And so in a setting where we'd really, these patients really might need acute care, we're already talking about a medication that most practitioners are very familiar with. So I've highlighted one article here to highlight just the idea of how many patients they use ketamine for outside the operating room. And this is a study looking at almost 23,000 children that got ketamine, mostly in an emergency department setting. So there's huge numbers of these patients that are treated, a lot of good data, again showing that it's a really relatively well-tolerated medication. And then finally, there's more indications. So the last couple of years, S-ketamine, which is an enantiomer of ketamine, nasal spray was approved for treatment of severe depression. And so another clinical use of a medication that's been out there for a while, mirrors maybe a little bit some of the intranasal formulations for benzodiazepines and how they're used. So, there's a lot of interesting things going out with ketamine, and I think it really shows a lot of potential as maybe the next agent that would be developed. And I'm not the only one that thinks that. I think we've been thinking of this for a while. So there's a proposed trial for this that I think will be very interesting. So the ketamine add-on therapy for established status epilepticus treatment trial, the KESSET, is a trial that's been in planning for a while. I'm taking this data from an AS abstract from last year about what they were looking at, but essentially it's a proposed study, a ketamine add-on, and what they'll do with this, the plan is, as of this abstract last year, was to investigate whether ketamine added to levetiracetam is superior to levetiracetam alone for established status epilepticus. And I think that what will be really interesting about this is how can we, it'll give us some ideas, how can we use ketamine for epilepsy? It really hasn't been systematically studied. Most of the dosages have been geared, for sedation, right? So, they give bigger doses. So it'll be really interesting to see what comes out. How much do you really need for epilepsy and how well is it tolerated, right? So there'll be a lot of interesting things that come out of this, and I think a really solid lead for maybe a next step for a really great acute seizure medication outside of benzos. All right, so I'm going to talk just a little bit, really kind of scratch the surface about seizure prediction. This is more about what might happen. So we've already gone over a good number of studies with a clinical history, as we've outlined. We can predict seizure occurrence already, right? And we can treat it. This is clinically proven, right? So we can predict it to a degree, but we could probably do it better, right? So improving our ability to predict seizures beyond just what we get from clinical history mostly, I think really offers a very interesting possibility to take the next steps to make these treatments more efficacious. So I'm going to step back a little bit. This is a device that unfortunately the development has been abandoned, but I think some really clinical, it gives us some ideas of what we might be able to do in the future. This was a study by Mark Cook, and this was looking at long-term ambulatory intracranial EEG. And this was the first clinical trial to record long-term intracranial EEGs in an ambulatory setting and show that there is successful prospective seizure prediction, right? It's easier to detect seizures, but actually to predict them ahead of time is difficult. Their data showed that the seizure predictability showed sensitivities ranging from 65 to 100% in 11 of the 15 patients they studied. And I'll just show a little bit here. I just think it's interesting with devices. We'll have to think about how we integrate this in. But this is looking from the study which Mark was first author, looking at monthly seizure rates. And we see this with most devices, that people maybe report 0 seizures, right? But the number of seizures that are detected by the device is a lot higher. So in some of these patients, they didn't say they had any seizures at all over the month, but they might have hundreds of seizures, right? So we have this disparity, potentially a more sensitive measure. It's a little complicated how this is interpreted, but I'll talk about a little bit at the end. But that's very typical for these trials, and that's what was found with the study. Mark Cook is first author. And so what I'd like to do is I want to just talk about a case report as a personal communication from Mark. So what could happen? This is a bit anecdotal, but I think you look for the future, you see what might happen as we go on. So Mark let me know about a patient in the study, a university professor, which I understand sometimes don't follow instructions very well by rumor. Would certainly be the case in this person. So outside of protocol, they decided that they would just discontinue all their regular scheduled anti-seizure medicines. So it didn't work anyway, they stopped it. So they did that on their own. And then what they did is using real-time seizure prediction, they took clonazepam. So the way these devices were set up, it had a light that if you were at a relatively higher probability of having a seizure, that light would go off, right? So it was kind of had this running prediction of what would go on. And so this person would look at what their risk of the seizure would be, and when they had that, they would take a clonazepam, and anecdotally, he reported that he had no seizures, right? So, this wasn't the focus of the study, but I think this puts out there what we could do, right? If we had something that really predicted seizures really well, we could just give intermittent treatment, right? We wanted to give treatments all the time. And, probably a way it'll come out, we'll have complementary ways to do that. It might not work out just like this, but I think it really holds a lot of promise for us to be able to think about how we use our medications and to use them really effectively for patients in the future. Sorry, this mouse wheel I haven't figured out yet, so I always go back, but... So I'm going to just really scratch the surface about these cycles in epilepsy. This is a really interesting area. Very luckily, the scientific committee program on the symposium on the last day of the meeting is going to cover this in a lot of detail, so I'll shout that out. They'll go into a lot of the details of this area, which I think is really exciting. But it's basically looking at these cycles in epilepsy and how we can predict this, right? And when these things are studied carefully, with devices, and some with clinical history, we find that there's a lot of things that go on with seizures. I think naturally, clinically, we just ask patients what happens in a day. There's times I've used seizure calendars and things like that, but that's the core way we've kind of thought about this, is that the circadian rhythm, do people have a run of seizures in a day? But now we have good data to show that this can happen in multi-day rhythms. So maybe not every day, maybe it's every third day. Maybe it's every fourth day. There's different ways this works out with individuals. Also on a yearly basis, that they can happen. They can have times of the year where there's more going on. So if we had really good data about that, right, we'd be able to predict when we give our medicines more, right? And so I think, again, this is something that can really make a difference for treatment and to kind of go hand in hand. And just really, again, to scratch the surface on this, we have a lot of devices for seizure detection and prediction. And this is a really interesting area. There's all kinds of stuff going on. These have a recent article by Fu and Lotto did a really nice review of these and split things out into non-invasive devices that typically did not use EEG, but there's a lot of different biomarkers that can be used to be markers of seizures, and there's a lot of stuff out there, watches and all kinds of things. I'll let you read all that are there, but there's a lot. And then my personal feeling is EEG-based devices are going to be the best, right? They're the most specific data. But there's a lot going on with that as well. There's development of long-term subcutaneous and subgaleal EEG, as well as currently available responsive neurostimulation, right? Where we are able to measure these over the long term. So how we put that together with treatments, I think will be really interesting in the future. So just a couple of things about moving forward. So, you know, I just looking back over things, what are some of the challenges we're going to have going forward? And I think that, again, I always say, well, you know, seizure prediction is going to be great. We can use it, but we do use it right now. Okay, we do use it from clinical data. We can predict seizures. It's not great, but we need to find ways to complement that, right? How can we do it better? And there's a couple of things that will happen. One is that I think it's going to be really important to use individualized algorithms of seizure patterns to see how we can enhance intermittent treatment, all right? And there's a couple of things that's going to require. And one is going to be, how are we going to define acute repetitive seizures? As we just talked about, there's this complicated inter-individual variability between patients, right? And so if for each patient, we're probably going to need to come up with an individualized plan. And so that makes it tough to go back to a big global definition of what these seizures are. And this goes back to the same thing that Cesare Lombosa was talking about. You know, do you have a really cast in stone definition? There's theoretical advantages, but does that help us in treating patients? And so I think that's something we're going to have to work through. I wish I had an answer for that, but I think it'll be important. The other thing I'd like to talk about a little bit, you know, as a clinician, I really understand the importance of clinical seizures, right? I mean, I think we see a lot of things on EEG. I love EEG, but you know, at the end of the day, clinical trials are run by counting clinical seizures. And you know, as I just illustrated with Mark's study, and there's many others that go on about this, is that we see a lot more events on when we do monitoring than when we see clinical seizures. So how do we work that in? It's certainly not that right now. That's not the way we look at medications for approval. We look at clinical seizures, not detected seizures. So again, I think the FDA's done the best they can with new things, but this will be a really important thing we need to address as we go forward to know how to integrate this different data into a clinical setting. Okay, y'all, I'm going to summarize, and I appreciate your attention, but what I've tried to talk about is our historical experience and how it really informs our current care for patients for acute seizures as well as acute repetitive seizures and epilepsy. We have a lot of good treatments right now, so don't forget that. I think I've really helped a lot of patients by looking at available treatments and using them. And most of those available treatments right now are benzodiazepines. However, in the future, I think it's going to be really exciting. You know, I think there'll be new agents, and I think the prediction, right? If we could really predict our seizures better, we could really make a bigger impact for seizure control. So I will conclude, and again, I very much appreciate the opportunity to give the Hoyer Lecture, and thank you very much.
Thank you very much, Ed, for that terrific talk. So just as a final note, I'd like to take a moment to share with you an opportunity to further engage in the diagnosis, prevention, and treatment and eventually cure for epilepsy. So as you heard in Representative Hoyer's talk, there is a national plan for epilepsy, which is under development and has actually been introduced in the Congress. And AES supports this plan. And there are two ways in which you can get involved. And one is that you can ask your legislators to support the newly introduced legislation. And you can also more immediately join work groups that will draft recommendations from the epilepsy community for provision to policymakers. So we are looking for volunteers from across the epilepsy community to contribute their expertise. And you can scan the QR code on the screen or visit the AES website, which is also listed there, to let us know your interest and find out more about how to get involved. So thank you very much for attending the Hoyer Lecture, and we wish you a wonderful rest of this very exciting meeting.